Assalamualaikum warahmatullahi wabarakatuh. Ketemu lagi dengan kami dari PT Melalui Jaya, di mana kami adalah channel partner dari GI Healthcare yang sudah menjual ultrasound lebih dari 30 tahun. Baiklah customer GI Indonesia, di sini dengan kita masih di channel MHC Ultrasound. Kami akan memberikan informasi mengenai fetal cardiac imaging in early gestation dengan Profesor Elena Sinkovskya. Mohon maaf jika ada kesalahan untuk penyebutan nama. Baiklah, kita saksikan berikut informasi dari
Hello,
beliau.
and thank you for joining today's webinar, Fetal Cardiac Imaging in Early Gestation. My name is Kathy Elliott, and I'm the Marketing Director for Women's Health Ultrasound at GE Healthcare, and I'll be your moderator. And now I'm honored to introduce our esteemed presenter for this evening, Dr. Elena Sinkovskya. Dr. Sinkovskya is a professor of OBGYN, Director of Ultrasound Research and Education, and Program Director of the Fetal Cardiology Fellowship at Macon and Joan Brock, Virginia Health Sciences EVMS Group at Old Dominion University. She will discuss guidelines, tips, and techniques for comprehensive fetal heart evaluation in early gestation. Welcome, Dr. Sinkovskya. The floor is yours.
Thank you, Kathy, for this great and kind introduction. It's my pleasure to be here today, and I'm very excited about the new meeting virtually with all the GE customers and the GE team. Today, we are going to make a journey through the cardiac imaging in early gestation. And nowadays, I think this is a very important skill to get. And I would show you why you absolutely have to know how to evaluate the fetal cardiac anatomy in early gestation. So with that, I would like to begin. So I'm going to turn off my camera so to make sure that all the video content comes across the highest quality. And in a few minutes, we will begin. So fetal cardiac imaging in early gestation. In the next hour, I would be happy to review the national and international guidelines for fetal cardiac imaging in early gestation. I will demonstrate systemic approach to the fetal heart evaluation in the first trimester using the standard ultrasound planes. We will describe the role of the different color Doppler modalities in the cardiac evaluation in the first trimester, and spend some time on the highlighting the safety aspect to make sure that we eliminate any anxiety related to use of color Doppler and early gestation. And I will present also the utility of the volume imaging for the diagnosis of the cardiac anomalies between 11 and 14 weeks gestation. So we have a very ambitious plan for today. But before we're going to talk about the fetal cardiac anatomy in the details, I would like to highlight the two different approaches that can be applied to the cardiac imaging, not just in early gestation, but basically at any time during the pregnancy. First approach is the screening examination. As it goes from the definition of the screening, this is something, the exam, that performed on everybody at certain gestational age. And basically, this is the exam that is applied to the general population. We will look at the fetal heart using the transabdominal ultrasound for the most cases. And we will be looking at the direct, but mostly indirect markers of the cardiac anomalies. And for using this, for doing this examination, we need the basic training for the examiners. So that needs to be sonographer who performs ultrasounds in the OB office, but also an MFM. And ideally, that would be great if that person has some sort of the first trimester standards qualifications or certifications, such as through NTQR or the FMF. And basically, this is the exam that is performed in the doctor's offices, like regular OB offices, but can be done in the MFM settings. And for the most examination performed between 11 and 0 and 13 weeks gestation, generally speaking, but the best window for doing the cardiac screening examination is indeed between 12 and 0 and 13 and 6. And the ultrasound modalities that can be utilized for this type of the exam, it's the 2D imaging with the Doppler technique. So the fetal echocardiogram, from another hand, this is a very specialized exam that performed by indication. So usually the screening examination, if abnormal, so fits the fetal echocardiogram volume. So then we can utilize the transabdominal and transvaginal ultrasound. We will utilize the multiple planes. We will look at the gestational age between the 14 and 16 weeks gestation. And most of the time, this type of the exam for interpretation requires the extra training and the expertise, and ideally the pediatric cardiologist should be involved. And of course, in terms of the ultrasound modalities using for this type of the exam, we are not limited in any technique, so that basically any technique ultrasound method that is available for the cardiac evaluation, including the 2D, the different Doppler modalities, stick, and others can be utilized for the fetal echocardiogram in early gestation, pretty much the same way how we are doing that in the standard time between 22 and 24 weeks gestation. So that idea is that we do screening to select the high-risk group where the fetal echocardiogram will be performed. So, and with that, I'm going to focus mostly on the screening techniques for this presentation, and then we will touch a little bit on the fetal echocardiogram. So how the screening of the cardiac anomalies initially started. It's very deeply related to the introduction to the clinical practice of the nuchal translucency measurement that happened more than 20 years ago. So here you can see the two fetuses, the nuchal translucency measurement in normal and abnormal condition. And here you can see that strict criteria that need to be followed to obtain the perfect view to measure the nuchal translucency. Nowadays, the nuchal translucency that initially was introduced to the clinical practice as a screening method for the chromosomal problems, in particular Down syndrome, really lost this value to the non-invasive prenatal test. But we still feel that the value of the nuchal translucency is there for the early screening for different anomalies, and in particular the cardiac anomalies. And this is because the nuchal translucency and the incidence of the cardiac anomalies is very much related. And here you can see that in the fetuses that normal karyotype, the nuchal translucency increases exponentially once you reach a certain point, usually it's the 3.5 millimeters, and then the incidence of the cardiac anomalies significantly increases, so making the nuchal translucency the independent risk factor for the cardiac anomalies. So that was the first step for the screening of the cardiac defects in the first trimester. Later on, we also added another marker, which is the pattern of the blood flow in the ductus venosus. And here you can see the fetus at 13 weeks gestation. And this is a sagittal plane where ideally we need to interrogate the ductus venosus. And the typical blood flow pattern in the ductus venosus that demonstrates 3 waves. This is the flow during systole, during early diastole, and then decrease of the flow during atrial contraction. But take a mental note that during the entire cardiac cycle, the blood flow in the ductus venosus directed towards the heart and should not be negative during atrial contraction or going down to the baseline. So the reverse of flow during this time would be considered abnormal, and I will show you some examples in a second. And finally, we can take a look at the heart, and we can visualize the four-chamber view directly and even measure the pattern of the blood flow across the tricuspid valve. And here you can see how in early gestation, the blood flow across the tricuspid valve has this biphasic appearance. There's the relatively low velocities in early gestation that indicates the stiffness of the myocardium at that gestational age, and the blood flow during atrial contraction that you can see here. So, and the pattern of the blood flow through the tricuspid valve, the important area to look at, it's in in the diastole, so in between we're not supposed to be able to see any evidence of the tricuspid regurgitation in the normal heart. So looking at those parameters, putting them all together, here is the performance of the screening for the major cardiac anomalies that can be estimated individually on the case-to-case basis. And you can see we will screen by the nuchal translucency alone. We will see that we will detect about 20% of all major cardiac anomalies. And if we will put them all together, the normal nuchal translucency, the ductus venosus, and the tricuspid regurgitation. So if one of those three is abnormal, and we will fix the rate of the false positive results below the 5%, so that we will be able to detect about 50% of all major cardiac anomalies. So sounds fantastic. And this was was going for a while until we realized that our technologies allow us to take a look directly at the heart, and we can evaluate the structure of the heart using transabdominal and transvaginal ultrasound, and that we can achieve the very good resolution, and in particular after 12 weeks gestation. So here you can see the recent guideline from the International Society of Ultrasound and Obstetrics and Gynecology that was revised in 2023. And here you can see the approach to the cardiac imaging that is recommended by that society. So technically we can see and do two types of the examinations between 11 and 14 weeks gestation. If we are doing the basic assessment, so that the requirements are relatively narrow, so that we need to see the heart inside the chest, and that we need to evaluate the axial plane at the level of the full chamber view. But if we are performing the early anatomy screening, so that more detailed ultrasound, so here we can see that in the chest, and in particular looking at the heart, we can and should evaluate not just the cardiac activity. We need to establish situs, we need to establish the cardiac position, we need to look at the cardiac axis, at the cardiac size, we need to get the full chamber view, this color and without, left ventricle outflow tract. We need to look at the pre-vessel and trachea view, again on the grayscale and the color Doppler, and then we need to confirm that there is no evidence of tricuspid regurgitation or the abnormalities of the blood flow in the ductus venosus. So quite an extensive evaluation. But what is our national guidelines saying? Here you can see that the situation is pretty much similar. So we have the AIM, American Institute of Ultrasound and Medicine guidelines for the standard diagnostic ultrasound that also doesn't require much. But thank you to the tremendous effort from Dr. Bromley in 2020, we got the AIM practice parameter that opens the new chapter in the ultrasound imaging in early gestation. And this is the guideline dedicated to the detailed diagnostic obstetrical ultrasound that should be performed between 12 weeks and 13 weeks and 6 days. So basically between 12 and 14 weeks. And this is comprehensive exam that should be performed by indication. And here you can see the long list of indications. So this is really a lot of patients will fall on one of those categories. And what's really new, just hot off the press, that we, in the past, many practices were really hesitant to utilize those parameters and push forward because despite the fact that we had that, we were not able to bill for those services. But now we have a dramatic change in this situation, and now the code 76811 can be billed twice in the first trimester for this detailed ultrasound, and then in the second trimester. So this is significant shift in the paradigm how the ultrasound can be performed, and this is something that really need to be taken in consideration, to be familiar with, because this is the future of our ultrasound practices. So let's take a look into details and what is the detailed assessment of the fetal anatomy suggests, in particular that we are looking at the structures within the chest. So that the fetal chest, you need to be assessed according to that ARM guideline, that we need to look at the axial planes. That required for those axial planes is the cross section at the level of the four-chamber view, where we need to note the cardiac position and the cardiac axis. We need to obtain the four-chamber views without color and in grayscale and with color, and we will talk in details what type of color preferred for this time of the pregnancy that gives the most diagnostic information. Then it's required to get the free vessel and trachea view with color, because most of the time it might be challenging to look at the free vessel view without using the color Doppler. And then we need to confirm that we have the homogeneous and symmetric appearance of the lungs parenchyma, and that goes along also the position of the heart within the chest. If something looks abnormal but you are not sure, and if you are, and also you are not ready to call this heart screening positive, so you need to require to complete a couple extra steps in the evaluations that include the measurement of the cardiac axis, the evaluation for the tricuspid valve regurgitation. And of course, if we have some concerns for the chest being narrow that early, we also need to make sure that the ribs and normal shape, length, and densification. Again, this is what needs to be evaluated in terms of the assessment of the anatomy of the fetal chest. So also, as we are doing this in the second trimester, and here I would like to present the protocol that we utilize in our department. So we have some sort of the combination between the ESWAG and the ARM guideline. So, and as you probably heard before from me, that the assessment of the heart usually starts in the abdomen. So this is a technique that indeed is true for the first trimester as well, because the first step in the evaluation of the heart indeed needs to be the assessment of the fetal position within the uterus, and then the evaluation of the situs. And the situs can be evaluated using the sweep technique. Then we start from the upper abdominal level. This is a level where we can visualize the baby's stomach, and then slowly we will move to the chest, and we need to be able to see that the stomach and the apex of the heart are pointed to the left, so that we establish the position of the fetus within the uterus. We assign the left and right, and then we will take the sweep, really noticing if the stomach and the apex of the heart on the same side, and if the side is left. So this is the first step in the assessment. So here I would like to show you two still images on the fetus. That was the cephalic presentation around 12 weeks and 6 days. And you can see here right away that the stomach is on the right side. It's displaced very much posteriorly, that the apex of the heart is pointing to the left, and that the descending aorta is on the right. So just looking at those two still frames retrieved from one sweep, we can suspect at the same time the major issue, that the situs and the cardiac anomaly, because most of the situs abnormalities, they have the abnormal cardiac anatomy along with that. So, and again, here we have a few things. We looked at the position of the stomach, we looked at the main vascular structures that sometimes not that easy to do. But what's really important to note at any gestational age, the position of the descending thoracic aorta, and then it's on the right, we can suspect right away the aortic arch abnormalities. So this is how the just two simple pictures can be interpreted and getting us a lot of clues for the anatomy of the heart. So the next thing that we need to look at, this is the cardiac position. And this is where we need to utilize the virtual, or we can even draw that line that pretty much divides the chest into two halves. And the normal heart in early gestation and later usually occupies, the heart is located, most of it located on the left from the midline, and 1/3 of the area of the heart located on the right from the midline. So this is the brief presentation, and we can see that this is a normal cardiac position. So we will start from the very obvious abnormalities of the cardiac position that should not be missed in the first trimester. And the first trimester and that detailed exam aims to detect the most severe malformations. And of course, then we can see this condition that's called the ectopic heart, that it's typical for the condition called the pathology of control. So if you see the heart beating in the amniotic fluid, this is definitely abnormal. 100% we need to detect this abnormality. This also feeds the pathology of control, but we can see that the heart also is not within the chest. It's located within the large abdominal wall defect. And also I would like to point out here that the nuchal translucency is enlarged, and that here we have the large abdominal wall defect that contains the heart, the liver, and the stomach. So in pathology of control, we have the agenesis of pericardium and the defect in the diaphragm or the chest wall. So this is why the heart being displaced from its typical position within the chest. So this is the thing that malformations that we absolutely have to pick in early gestation. So this is the examples of the abnormal position of the heart due to the diaphragmatic defect. And these two cases are pretty obvious, and we can see not just the displacement of the heart to the side, but also the stomach within the chest. So this could be tricky because the stomach is not located within the chest, but if we will imagine that line that dissects this chest into two equal halves, we will be easily to detect that the most of the heart is indeed located in the right chest, and that indicates the dextro position that is typically occur in case of the diaphragmatic hernia. So another condition that can be detected in terms of the abnormal cardiac position, that the heart sits in the middle of the chest, and this is a very typical situation for malformations related to the situs issues. For example, this is the baby with the left isomerism. We also see that the heart rate is kind of slow, but also we have the central position of the apex that is pointing straight right behind the sternum. So the next important marker for the cardiac anomalies that we are visualizing the four-chamber view, this is the assessment of the cardiac size. We all know very well that in the mid-second trimester, the cardiac size is about 1/3 of the area of the chest, but in early gestation, this is a little bit different. So that studies from Europe and our own observation also noticed that a normal heart will take about 1/4 or 1/5 of the heart, so that the normal area of the heart, if we'll measure that would be about 20-25% in the first trimester. And once you will see the heart that would be measuring about 30% of the area of the chest, so the cardiothoracic area ratio, so you will see that that would correspond to this significant cardiomegaly. It's important to keep it in mind and not undercall the cardiomegaly. So this is two examples of the cardiomegaly. We can clearly see that this heart is big and this heart is big, and sometimes you don't really need to take the measurement. It's so obvious that this is abnormal. So here we deal with the tricuspid dysplasia, and this is the fetus that has the severe pulmonary stenosis that early, as well as the early onset of the twin transfusion closer to 14 and 6 weeks gestation. So that was the recipient twin. So the next parameter that is important to pay attention to. This is the position of the cardiac axis. And the cardiac axis, this is the angle that the interventricular septum makes to the midline. Again, we are going to utilize that virtual line of the midline and the chest on the cross-section view. So usually cardiac axis establishes its position by 12 weeks gestation, and then it stays unchanged through the pregnancy. And in early gestation, the normal measurements of the cardiac axis is between 30 and 60 degrees. And in the second trimester, that a little bit widens. The normal range is between 25 and 65. So we did some research in our institution that was published now more than 10 years ago. And you can see here that out of the cardiac anomalies diagnosed in the first trimester, about 2/3 had the abnormal cardiac axis, and the abnormalities that you can see, most of the fetuses, about 56%, they had the deviation of the cardiac axis to the left, about 10% had deviation to the right, so that it was more like central axis. And the third group, which was about 9%, this is the axis that cannot be identified because we were not able to find the septum and visualize that clearly. So this is a very important group of the abnormalities because this usually constitutes the hearts with one functional ventricle or univentricular hearts. And this is the most severe cardiac malformations that after birth, the complete repair for those malformations not possible, and we will do the stage palliative care. So to detect them early is important. So here you can see the comparison of the screening for the cardiac defects, major anomalies, using the cardiac axis versus nuchal translucency. And you can see that for the patients with the normal karyotype, so the cardiac axis would perform much better for all categories of anomalies and beat the nuchal translucency. So the direct evaluation of the POCHI and the views of assessment of the cardiac axis is really preferred for successful screening for those malformations. Another important aspect of the cardiac evaluation, and you can see that even very, very basic assessment of the heart requires paying attention to the cardiac activity. And the cardiac activity, it's not just the fact that the heart is beating, but also we need to attempt to look at the cardiac rhythm. And this is just a reminder that the normal cardiac rhythm is really there, should be recognized that early. It should have a lot of variability, so the heart rate is changing over time. And so the rate should be between 120 and 160 beats per minute. And what's really important for the technical component of getting this, that the national guidelines require to utilize just a mode as the primary method to look at the cardiac rhythm. So this is important to keep in mind, in particular, because this is important in terms of the safety aspects, and we will talk about them in a minute. So here is an example of the abnormal rhythm, and very often, if you don't really utilize the assessment of the atrial and ventricular rate and just do the assessment of the heart rate even outside the heart, so you may get the controversial results, like that you see the bradycardia and then kind of the rhythm is normal. So this is what happens in the major cardiac malformations associated with the sinus abnormalities. Here you can see the left isomerism. This is complete V canal, common atrium. We can see the double barrel sign behind that common atrium, indicating that this fetus also has the interrupted IVC. So in here we have the heart rate, which is different. For the atria, we have normal 144, and for the ventricles, it's 70 beats per minute. So that this is already indicates the block and this is important finding. And finally, we need to make sure that there is no pericardial or pleural effusion noted, and this is where we need to attract our attention, looking around the borders of the heart and the borders of the lungs. So here I would like to show you examples that you should not panic when you see the picture like that at 13 weeks gestation. Looks like it's a lot of pericardial effusion, and this is the picture at 17 weeks. So what's causing that? If you look very, very carefully, we will be able to see the very, very thin structure that arising from the apex of the heart, and it gets smaller over time in 17 weeks gestation. If you look carefully, you can see it right here at the apex. This is the diverticulum or outpouching that rubbing against the pericardium and create that pericardial fluid. So I think that for many specialists in maternal fetal medicine, this is where you want to take the needle and drain the fluid, but hold your horses, because most of the time, by the 25 weeks, that completely resolves and doesn't require any intervention, and it was also published in the literature. So of course those cases are not very common, but this may happen, and this is very, very benign prognosis. So this is something to keep in mind, that the pericardial fluid, especially this type of massive pericarditis, can be caused by those small diverticuli, and they are benign. So in contrast, the bilateral pleural effusion, in particular early, this fetus even 10 weeks gestation, so has a very, very poor outcome on our internal evaluation. We had about 25 cases of the presentation of bilateral pleural effusion that was really associated with the very poor outcome, that half of the patients ended up as a demise in a week after this ultrasounds being done, and high association with chromosomal problems, in particular Turner syndrome. So how about the anatomy of the four-chamber view? The resolution of our ultrasound equipment, especially if we use the high-frequency probes, if we use the improved contrast techniques such as the dynamic contrast, the shadow reduction, and all the algorithms allowing us to bring the contrast to a different level. So it allows us to see the four-chamber view and the other cardiac anatomy pretty much the similar clarity and resolution like in the early second trimester. So that's why we will recognize in this chart the left ventricle, the right ventricle, the moderator band or trabeculation at the apex from the right side, which is typical, and all the other markers that we usually look at in the level of the four-chamber view. So what's important to recognize, so this is a very good axial plane at the level of the four-chamber view, and we can see here just 3 chambers instead of 4. So we have the left atrium, the right atrium, 1 AV valve, and the 1 ventricle to the moderator band. So this is univentricular heart, mitral atresia, and this is single right ventricle. So very severe malformation. Point out that here we cannot measure the cardiac access. Again, this is really a good picture showing that major cardiac malformation. Another example, sometimes to improve the resolution, we can utilize the different tint maps, and there are plenty for you to choose from. As you know, the tint map makes things look better and more contrast, because in the shades of color we can see much better than using the shades of gray. And here we can see the typical appearance of the fetus, the complete EV canal, where we have the common EV valve, septum, primum ASD, and the large inlet VSD. And looking at the generalized edema, I think that here we can recognize that that fetus has the chromosomal problem, and the CVS confirmed the Down syndrome. Here we have another example of the univentricular heart. Again, 2 atria seen. The left atrium is so small that cannot be recognized. but this is sufficient enough to send patient for the detailed assessment and the counseling with the pediatric cardiologist. So another very important view is the prevascular trachea view that demonstrates the spatial relationship between the major vascular structures such as the pulmonary artery, the aorta, and superior vena cava, and their relationship to the trachea. So here we can see that in the first trimester, most of the time in the abnormal cases, we can see just one big vessel and the superior vena cava or even two superior vena cavas. So this is a very, very specific change at that plane for many malformations. So, and of course, adding color to our grayscale imaging changes our understanding of the physiology of the cardiac circulation and may significantly help, in particular when the just grayscale alone doesn't show us sufficient details. There were multiple papers using the algorithm that includes the four-chamber view, three-vessel trachea view, and grayscale in combination with color that demonstrates that the different patterns can be recognized of the different cardiac anomalies, very clinically significant, and how we can utilize that for early detection rate increase of these malformations. So there is a lot of anxiety to use color Doppler in United States, in particular in the first trimester. And I think that the only thing that should be significantly emphasized here that by following the specific guidelines and the safety protocols and the statements which are published and available, you will minimize the potential harm that so far nobody really proves that it's there. So that's the terminal index needs to be dropped below 0.7, and the modern ultrasound machines absolutely allow you to visualize that parameter. And also adherence to the ALARA principle, which says that as low as reasonably achievable. So it's another key component of utilizing Doppler in first trimester. And to my mind, the benefit that you can get from using color Doppler, in particular when you're trying to figure it out if that heart normal or abnormal, definitely overweights the potential risks if you adhere to that safety considerations presented here. So the ESWOG also has its own safety statement, and again, this modality should not be used during the embryonic period, so prior to 10 weeks gestation, but in between 12 and 13 and 6, this is where we perform our detailed ultrasound. It's considered really a valuable tool, and I think that we all need to utilize that and be familiar with that. What are the benefits to use the color Doppler briefly for the cardiac assessment? So we can utilize that to visualize the four chambers, in particular to visualize two separate inflows that in return can help you to evaluate the cardiac axis and navigate where the interventricular septum is. It can help you to visualize the discrepancy in size of the cardiac chambers, and in particular the left and right side of the heart. And here you can see the early detection of coarctation and the hypoplastic right heart syndrome. And again, the four-chamber view will allow you to get the septum, and even if the cardiac axis is okay, you can clearly visualize the discrepancy in size of the cardiac chambers. So here we can see the patient that was referred for early assessment with a very poorly controlled diabetes. And as the A1C rises over 10, so this was the case, we may expect a major cardiac structural cardiac anomalies. And if you look at the four-chamber view, it looked pretty much okay. We can see some fluid here, which is not that uncommon to see on the diabetic patients in the first trimester. But application of color surprised us with that significant amount of the mitral regurgitation and a little tricuspid regurgitation. So we utilize the spectrodoppler to make sure that this is a true regurgitation and got the confirmation of that. And so here you can see how the heart looked at the second trimester. So here we can clearly visualize that it was the complete ED canal with relatively small ASD and VSD, but it was detected and the patient was brought back early for the second trimester evaluation, and that major cardiac anomaly was diagnosed. This is basically illustrates how color can help you to put the patient in the high risk category where the follow-up will be indicated. Speaking about the importance of the color Doppler, utilizing that for the assessment of the pre-vessel and trachea view. So in both of those cases, we had just one vessel visualized, and the 2D imaging in application of color Doppler allowed us to visualize the other vessel that shows the reverse flow here in the aorta, aortic isthmus, and the ascending aorta, consistent with the severe obstruction of the LVOT. And this is the example of the early diagnosis of the absent pulmonary valve, where we have the reverse flow through the ductus arteriosus and back to the right ventricle. So here are just a few rules about the color Doppler imaging optimization, and I would like to emphasize that the adjustment of the 2D image should be performed first before you try to apply color. It's important to utilize the appropriate preset, for example, the first trimester hardware in T that is widely available, and then to play with the color gain and the balance to avoid some artifacts. But also it's very important to be familiar what type of Doppler modalities are available. And as you can see, our menu of the Doppler imaging techniques include a lot of possibilities. We have the conventional color Doppler, the HD color Doppler, the power Doppler, slow flow, graphic flow, and most of those modalities can be combined with the volume imaging and presented in the 3D effect, which is the radiant flow. So here the example of the color Doppler, the conventional color Doppler that applied to visualize the ductal arch, and then we can follow the descending aorta. So this is our HD color. Here we can see more details, including the IVC and the hepatic veins. And then we can use the regular power Doppler. So this one just shows the blood flow without specific utilization of the direction of that blood flow. And finally, we have the new type of the color Doppler imaging that also combines that with the navigation through, and this enables the visualization of the specific trajectories of the flow within the lumen of the vessel, that also can be very helpful for visualization of the vascular structures in early gestation. But to my mind, one of the most useful Doppler techniques for the first trimester cardiac evaluation is the slow flow. So that is the Doppler technique that specifically designed for the vessels with the very slow velocities, and because of in that gestational age, even in the heart, we don't really have that high velocity flows. So that allows the maximize the visualization of the vascular structures. So slow flow, just a reminder, available in the different color maps, so you can pick the one that you like the most. I usually utilize 4 and 8. This is my 2 favorite, but if you live on the West Coast, you probably will want to go with the 7. So what's important to remember, sometimes when you start using the slow flow, you may feel that it's very bleedy and everything blending in. So that utilize the single tool is really critical, because looking at that video, you can easily go through the single frame by frame and retrieve the 4-chamber view and the LVOT with very significant and sufficient clarity. It can be applied for any vascular structures. For example, we can reconstruct the circulatory. We can look early at the pulmonary veins as presented here. We can combine the slow flow with the 3D imaging and get this artistic images using the transvaginal probe. But of course, the early imaging and even beyond the 14 weeks gestation prior to 16, this is something that this technique is utilized for. And again, the most of value is to see the pulmonary veins. This is something that we always struggle, including the second trimester, and identification where the descending aorta is together with the navigation where the intraventricular septum is located. And here, this is the three vessel trachea view. So utilizing the slow flow for assessment, we can clearly see the borders of the vessels, and even tiniest vessels such as the azygous vein, we can clearly identify its position and the drainage to the SVC. This is an example that I would like to illustrate the really value of this technique. So that was the challenging patient. We suspected the aortic coarctation, but the question was, is there any flow across the mitral valve, and is there any left ventricle left? And you can see that here we were clearly able to visualize the interventricular septum, and that left ventricle was called borderline. And here we were able to visualize the smaller aorta in contrast to the pulmonary artery, and to be vena cava and persistent LSVC and drainage of the azygous vein. So interesting enough, and it's probably hard to believe, but this patient was delivered the baby, and the coarctation was diagnosed, repaired, and this baby up until this day has the biventricular circulation. So that left ventricle was just small, but after birth was functional. So, and this is just a few cases to illustrate how critical the first trimester cardiac imaging could be for the management of the different challenging situations. So that was the patient who was referred at 11 weeks gestation and 4 days, the suspected monochorionic twin gestation, and on top of that we suspected the major cardiac anomaly on twin B. And here you can see the 4-chamber view of the twin B, and we clearly can identify the 4 chambers with just one single inflow, and there is no interventricular septum, so the cardiac axis cannot be measured. So this is within that group of non-identifiable cardiac axis. And the free vessel trachea view also showed, as we discussed before, the single big vessel at that area. So this is the twin A. In contrast, we can see 2 separate inflows, and we can see the perfect appearance of the 4-chamber view with all the markers typical for the normal 4-chamber view, the aorta, SVC, and both arches on the left of the trachea. So, and this is the same baby B later on the follow-up scan at 15 weeks gestation. So the changes persisted, and the diagnosis of the hypoplastic left heart syndrome, that the mitral and the aortic atresia was performed and made. But I would like to show here what the slow flow can bring the diagnostic abilities even on a different level. So we were looking for the pulmonary veins, and here you can see that the pulmonary veins, instead of joining the heart, were making the collector or confluence, and then we were able to visualize that they were, this is the collector, confluence, the vertical vein, and then we were able to see how that vertical vein through the brachiocephalic vein was draining to the superior vena cava. So it was also the supracardiac total anomaly spondylovenous return, and on the sagittal plane we were able to visualize not just that vertical vein and collector to the SVC, but also the all evidence of the hypoplastic aortic arch and the coarctation. So the second example, this is also twin gestation, but it's even more complicated. It's monochorionic monoamniotic twin gestation. So here we can see one placenta, two cords close together, one yolk sac, and two fetuses in one amniotic cavity. So here we have challenging scan. So the baby A was in the breech position, and we can see the clip that demonstrates the four-chamber view. Well, so here is the help of color that help us to visualize two equal inflows that we were able to clear the four-chamber view. The free vessel and trachea view was hard to see in the 2D. We suspected that it's just one vessel seen, but in the free vessel and trachea view using color, so we were kind of convinced that this is normal free vessel trachea view. So then we evaluated the other baby. Again, 2D is challenging. Color adds the confidence that this is two functional EV valves and four chambers present, and this is the free vessel and trachea view. And then we put them side by side, and again, this baby is cephalic, this baby is breech, and then we started to think about this as the abnormal appearance. If you look at the normal free vessel and trachea view, this is left, this is right, this is PA. PA should be always in the free vessel and trachea view, the most anterior vessel. Here we have kind of normal V shape on the left from the trachea, but the most anterior vessel is not pulmonary artery. This is the pulmonary artery from left to the right. It should be PA, aorta, SVC. So we can see that the aorta way too much up front here. So this is that baby A, that unusual and abnormal looking three vessel and trachea view at 15 weeks gestation, and what we have diagnosed here, the complete transposition. So it was suspected in her early scan, and this is how we were able to diagnose that. So of course, the minor cardiac malformations also can be detected using color Doppler, and this is a good example of the aberrant right subclavian artery. As you know, it's a marker of Down syndrome, as well as many other malformations and in these genetic syndromes. And in this case, we received the abnormal karyotype consistent with the George syndrome, and you can see how small the thymus is and how the great vessels visualized right behind the sternum in contrast to the normal three vessel trachea view and the normal thymus developing here. So would like to highlight and say a few words about transvaginal versus transabdominal examination. So definitely the transvaginal examination is the rescue technique. Then you have very insufficient visualization using transabdominal exam. And of course, the difficult patients, the difficult abdominal walls, we are struggling, and this is where the transvaginal exam can help. And you can see the visualization of the four-chamber view of the patient on BMI 50 in the first trimester, and this is the same fetus at 20 weeks gestation. You barely can recognize where the heart is, and this is actually located here. So that sometimes the first trimester transvaginal evaluation between 14 and 16 weeks gestation, this is your only window to the baby's anatomy, and I would highly recommend not to miss that opportunity. So fetal cardiac screening in early gestation, the ultimate goal, so that we talk about screening, so the ultimate goal is to identify the pregnancies and high risk of heart defect. So in this group, we can offer the fetal echocardiography, and this is what usually we perform together with our pediatric cardiology services. So this is the indications for early fetal echocardiogram. As I said, we usually perform that exam between 14 and 16 weeks gestation, and this is the indications that are basically utilized for that. So the early fetal echocardiogram is not different from what we are doing later. So this is the views that you all know very well if you perform the fetal echocardiography in the second trimester. That should be evaluated using color and using 2D. And here I think using the fetal echocardiogram for diagnosis, this is a lot of information in the literature that the 3D and the stick technology can definitely help when you perform that exams. And this is just a few examples how the 3D rendering can help to visualize the anatomy of the heart. And we can see teeny tiny details. This is the fetus at 12 weeks gestation. We can see even the false tendon in the left ventricle. So the resolution is really great. So here the utilization of the color Doppler together with the 3D rendering, we can see the four-chamber view, we can recognize all anatomical structures of the pre-vessel and trachea view together with the internal thoracic arteries as well. We can see and compare how the normal heart looks versus how the heart with a complete EV canal and a central jet of the tricuspid regurgitation in case of the EV canal looks like. We can visualize the complex heart anomalies. Here we have the right ventricle is completely missing. This is a little bit inlet ASD, so typical tricuspid atresia. But if you look behind the left atrium, we will be able to see double barrel sign that indicates that that fetus also has the interrupted IVC that is presented here as well. And finally, another univentricular heart. This is the hypoplastic left heart syndrome. We can clearly see just the tricuspid valve going. And what's really remarkable about those images that it helps not just to visualize the anomaly, but to significantly ease the communication with the other professionals, like the pediatric cardiologists, who are still very hesitant to consult the patients that early, and the other providers such as the surgeons, so that then they see pictures like that, they kind of feel more confident to perform the counseling. So, and to wrap up our webinar today, I just want to remind you that the spectrum of anomalies that we are going to see for the early echocardiogram is usually more complex abnormalities. Usually it's univentricular hearts because they're more likely to be picked during the screening evaluation. They have a much higher association with aneuploidy and potentially fetal hydrops. And this is just my recommendations that, you know, once you are using your skill on a routinely basis, it would be not as difficult as you think. You need to make sure that you adjust the presets, and again that the system has a lot of tools that can help you. And also it's important to remember all the anatomical landmarks. Keep in mind that the axial plane is very important, and you need to make sure that you have complete grip on each side of the chest when you're looking for that. Utilize the color Doppler, in particular the slow flow. That would be my personal advice. And then, of course, follow the guidelines and the protocols. With this, I would like to thank you for your attention. I would like to invite you to join us as the fellows for our Fetal Cardiology Fellowship. If you are young MFM or you are just finishing the MFM Fellowship. And thank you very much for your attention. I would be more than happy to answer all your questions. Thank you.
Terima kasih, sekian informasi dari kami, semoga bermanfaat dan sampai ketemu lagi dengan channel kami selanjutnya. Jangan lupa selalu ingat USG, ingat MHJ, bantu kami untuk like, subscribe, dan komen. Wassalamualaikum warahmatullahi wabarakatuh.